All right, hello, I'm Natalie Blagowidow. I'm here in Baltimore, Maryland, speaking to you today about women's health concerns. So to start our talk off, the first thing I'm going to do is just let you know what we'll be talking about. Ehlers-Danlos syndrome and hypermobility disorders are associated with a higher frequency of some of the most common gynecologic problems. But in addition, some things that most gynecologists don't see very often are seen at a fairly high frequency in EDS. In addition, pubertal maturation can worsen symptoms associated with EDS. So we're going to talk about all of those things in some detail. Which gynecologic disorders are there? The common ones are menstrually related disorders. Those include the number one, which is heavy menstrual bleeding, menorrhagia, painful menses, also called dysmenorrhea, and then to a lesser extent, irregular menstrual cycles, which can be anything, more often, less often, bleeding in between your menstrual cycles. So all of those occur a little bit more often if you have any of the forms of Ehlers-Danlos syndrome or hypermobility. Other issues that women face with hypermobility who are sexually active are dyspareunia, painful sexual intercourse. There can just be that in isolation, or there are vulvar disorders that there's quite a range of those that we'll talk about. And pelvic organ prolapse, which I'm just going to touch on because I know you have a whole separate lecture on the bladder, and I think you'll get a lot more information on that subject in that lecture. All right, so what happens at puberty? Well, unfortunately, symptoms of EDS can become worse with puberty, or if you've had a nice childhood, all of a sudden puberty arrives and your symptoms of EDS kick in. The biggest series, which is a very good one, French series in 2016, almost 400 women were looked at. This group had hypermobile type EDS, and of those who already had symptoms before puberty, about half got worse with puberty. If you were feeling you had the diagnosis, but you didn't have symptoms, 17% developed symptoms with puberty. And that's in addition to that first group. So now we're talking about, one way or the other, 70% are having issues. Now, why does this happen? There's conflicting data on the effects of hormones on connective tissue, joint laxity, on the tendons. They've done studies. Estriol, one of the estrogen hormones, decreases the formation of collagen in tendons following exercise. So that's one mechanism that's been proposed. Certainly we know that in pregnancy, joint laxity increases. It's thought to be related to all those hormones that are higher in pregnancy. Some really nice studies have been done looking at the menstrual cycle and joint laxity, but these were not in EDS women. So I think it's applicable, but not 100%. Heights did a study looking at ACL laxity throughout the phases of the menstrual cycle. And if I go to the next slide, you can see what happens in the menstrual cycle is all the hormones are kind of low right with the menses, and a few days later, bleeding ends, your hormones start to go up, and there's a little peak for ovulation, particularly of estrogen, but also a little bit progesterone, and even testosterone kicks in a little. And then the luteal phase, when that lining of your uterus is building up, progesterone really dominates, but there's another bump of estrogen. So one study showed this kind of increase during ovulation, so that's just estrogen plays a role in joint laxity. The other study said, well, what about, we see kind of joint laxity more in this stage, the second half of the menstrual cycle. So then is it a combination of progesterone and estrogen? We don't really understand it, but it kind of goes along with the increase in symptoms after puberty. And So that's the symptoms of EDS. What about the gynecologic issues? So as I said, the biggest bug of all is just the heavy menstrual cycles. Even worse in the vascular form of Ehlers-Danlos syndrome, all women with EDS can be prone to this. And you can see the studies ranged, just say it once so I don't have to repeat it as I go through the talk. Some of these studies were sort of surveys, a bunch of women are contacted, asked to give information. And so there's what we call a selection bias, where maybe you're feeling fine, you look at this and you pitch it in the mail, you've got issues, maybe you're more likely to fill things out. So the numbers, anytime you see a percentage incidence of something, it may be a little on the high side. However, and that may be also account why, 33% or 75%. Anyway, it's definitely a common complaint. Why does it happen with EDS? We think the weakness in the blood vessels that you can see with connective tissue disorders is a factor. And we're talking about not just the blood vessels, but the tissue surrounding the perivascular tissue being weaker. In addition, collagen will interact with the other enzymes and factors for clotting, something called von Willebrand factor, the platelets which help you clot. And this, if you have abnormal collagen, you have an abnormal interaction and you have heavier bleeding. And this is just, this talk has a lot of slides with words. So I had to throw a few diagrams in, just showing that, the bleeding, the blood vessels sort of, they atrophy, you bleed, and then they build up over the rest of the menstrual cycle. And this is where you just wish that you would have better clotting, or if you can't manage that, just to control the bleeding in some other way. So how can we do that? Well, one way is using hormones, and we have them in many forms these days. So we have the birth control pill, and again, many types of birth control pills. The mini pill, just progesterone. Well, birth control is the oral contraceptive pill combined estrogen and progesterone. Progesterone also can be in an IUD. It can be, there's a drug that is now in an implant. These have varied over the years, but it's a single rod that gets put into the upper arm and can also help. So can you use any of these? Sure. And here again is the list. I mentioned the pill form of progesterone, and I mentioned the implant, which is etonorgestrel, but there's also Depo-Provera, which is a shot every 3 months. All of these have been used, and studies have actually been done in individuals with EDS showing what's effective and what isn't. In this adolescent group, it was only 26 individuals, but they kind of broke it down in a way that was a little bit helpful. 9 out of 26 did great when they were just started on the mini pill. That's not often what we start with. We'll often start with the combined oral contraceptive pill, estrogen and progesterone, but it seemed to work well. And as long as they could take it every day, it was fine. If you start skipping pills, especially the mini pill, you're going to have abnormal bleeding. The other individuals, so the majority of these adolescents found, well, number one didn't work, and it might have been the mini pill, but it might have been the oral contraceptive pill. Those are usually what you start with. And they had to kind of switch to a different pill or the shots, or land on something that finally worked. And for some of those individuals, it would be the implant or IUD. A note about the IUD: that needs to be carefully placed. We know with Ehlers-Danlos syndrome, your tissue is a little bit more fragile. If anything's going to be tricky about it, ultrasound guidance is helpful. Occasionally, it needs to be done in the operating room, very rarely, but especially with vascular EDS, to be very cautious with placement. And also, you want the doctor who's doing these very often, not the one who just placed an IUD maybe 2 years ago and is ready to do another one. The goal, of course, with all of these hormonal treatments are not only to get you to have lighter menstrual cycles, that's not bad, but if amenorrhea, no menses could be achieved, that's ideal, and 70% had that happen within 2 years. The women who were studied, again, that large series I referred to, found that now that's now talking about EDS symptoms rather than bleeding. So bleeding control we just spoke about. What about EDS symptoms on these hormones? By giving a steady level of hormones rather than that fluctuation you have with your own menstrual cycle, it was found more improved on the progesterone-only pill, but even 15% on the oral contraceptive pill improved, and then others did not. So individuals who already had symptoms of EDS that were already getting worse around the time of menstruation got even worse on the birth control pill, which to me is very surprising, but it's 25%, you can't ignore that number, while 15% on the other hand improved. So the bottom line with these hormonal medications is it's a little bit of trial and error. Don't give up if the first one didn't work, but you may not be satisfied with the results and then have to move on. Now, what options are there if you can't use a hormonal medicine? For example, women with migraines with an aura are not supposed to use the estrogen-containing drugs for sure. And there are other contraindications. So there is a medication called tranexamic acid. It's an antifibrinolytic, which means it just doesn't let clots get broken down. It's an inhibition of the clot dissolving enzymes. 2 typos in the same line, sorry about that. But anyway, it's a very effective drug. You take it the first 5 days of your menstrual cycle, 3 times a day. And because it promotes clotting, there's sort of a concern, gee, this makes you clot more, you're more likely to have a clot in your leg or have a pulmonary embolism. Most studies don't show an increase, but that's always the concern, so there's a little bit of hesitation. An individual with any kind of vascular EDS or vascular issues along those lines, some sort of propensity to clotting already, this is not the drug for them. The other medication, or not vitamin C, over the counter, that can reduce blood vessel fragility, acting on the lining of the blood vessel, and also sort of interacts with collagen fibers. It's a water-soluble vitamin like all the B vitamins. If you're taking B or C vitamins, whatever dose you elect to take, you really need to stick with it. And then maybe if you decide, oh, this isn't working for me, I took a high dose and I didn't notice a difference, taper it down over a few days, because your kidneys just want to excrete a certain amount and they'll keep firing it out, and you'll end up being depleted if you jump from a high dose to a low dose. But that may be effective and helpful and pretty safe. Now, other abnormal uterine bleeding, as I mentioned, there can be bleeding in between cycles, more common in vascular EDS. And again, can be caused by polyps. Women with fibroids can have bleeding. So you want to just make sure you're evaluated for other causes, abnormal lining of your uterus. And if there's nothing else found, hormonal therapy is appropriate. Prolonged menstrual cycles or irregular menstrual cycles are reported in about 30% of women with EDS. Some who have polycystic ovary syndrome, I'm not addressing that in this talk, but that can be treated with metformin and other therapies. And so that's, just keep that in mind if you're found to have that. Painful menses. First of all, if you're having heavy bleeding, you're much more likely to have painful menses. Painful menses are very common in adolescents, but unfortunately in Ehlers-Danlos syndrome, it does not taper off. You have a child, a lot of people who have a vaginal delivery then will end up with much milder pain with their menstrual cycle. Again, not so for EDS. It's usually thought to be caused by increased prostaglandin release. Well, if you're bleeding heavier, you've got more of that being released. This is made in the lining of the uterus. It's supposed to help the muscles and blood vessels of the uterus contract But with all that trying to contract, you end up with pain. So what do we do to treat painful menses? Well, take away the bleeding. You're not bleeding, you're not having pain, you don't have menses, and that's the hormonal therapy we talked about already. But also, certainly non-steroidal anti-inflammatories. We're talking about ibuprofen, also known as, in the US as Motrin, very helpful. There are many other similar medications. And not to forget that not only do those medicines help for pain, but they will actually help with the nausea and diarrhea some women get with their menstrual cycle. Vitamin B, 100 milligrams a day, vitamin B6, magnesium supplements, acupuncture have all been shown to be effective in the treatment of dysmenorrhea and should be considered. Another dyspareunia, painful intercourse. And not many studies address this, but when it is addressed in a study, the number reported is pretty significant, 30 to 61%. That 31% was reported in the Castori, another very good study out of Italy, about 2012. He found that women who did not have painful menstrual cycles did not complain of sexual intercourse being painful. But of those who did have painful menses, 31% had pain on intercourse. And again, some studies found higher numbers. Why is there painful intercourse? It can be a number of different reasons: vaginal dryness, fragile tissue, swelling of the vulva, or irritated vulva. All of those contribute to painful intercourse. And just a little anatomics slide. So the vulva consists of the labia majora and labia minora, sort of this outer area of the, this is the labia majora, labia minora, and all of that can get involved in this. Vulvodynia is just that area I looked at. That area can just be in pain. Sometimes it looks perfectly healthy and normal, and there is no obvious reason for why there's a problem. You certainly want to rule out infection and lesions and things like that. But again, when those have been ruled out, it's vulvodynia without an obvious etiology, cause rather. It is a peripheral sensitization of the vulva that occurs that leads to the discomfort, but how to break that, it's very challenging. Now, sometimes there is something quite visible, the swelling of the vulva that can occur with intercourse, after intercourse, and in some women, unfortunately, is persistent and all the time. Here with EDS, we think that there's vasocongestion, the blood vessels are weak, and so the blood pools, and then it doesn't go back because there's something called venous insufficiency, where just that pumping the blood back up through the system doesn't happen, and it sits there pooling, and the vulva remains edematous. There's another cause related to dyspareunia, so not really painful intercourse, but a condition called persistent genital arousal syndrome. In this case, it's intrusive. I mean, genital arousal, I mean, you're supposed to have that with intercourse, of course, and have an orgasm and then find relief. In this case, it's intrusive. It's not related to sexual desire. It's not relieved by orgasm. It does not go away and can actually be either just this sense of discomfort and arousal or painful. And again, what normally happens is blood flow to the genitalia increase with sexual arousal, and you have genital vasoconstriction. Congestion, that's what's supposed to happen, and then it eases off and goes away. With the persistent disorder, there's systemic vasocongestion, and that laxity in the blood vessels lets everything pool, and the stimulation just doesn't go away. So what can we do to treat all of these things? And what I just talked about was a bunch of different things, but the treatments tend to overlap, which is why I've listed them together. Skin care, if there's anything to be seen externally, if there is any irritation. Physical therapy can be helpful. Psychotherapy can be helpful, cognitive behavior therapy, exercises, Kegels and reverse Kegels, and sometimes medications. And notice when you see a chart like this, diagram like this, if there's this many different treatments, you know that there's nothing perfect for anyone. But what's nice is this is organized to show what's maybe more effective and less effective. So you can kind of avoid these topical, if everything looks healthy and normal, these topical antifungals or steroids or antibiotics, whatever, this is not going to help. On the other hand, therapy with trigger point therapy, myofascial release, that can help. Estrogen just helps make the tissue just richer and can, if you have thin, friable tissue, can be very effective as a topical. And Tai Chi sort of snuck itself in here, although exercise is down here. So, again, it's a little bit of this and that, but a little pick and choose, and again, a little bit of try this or that and see what works is in order. In terms of medications, again, we have a list. Again, the list tells us there's no right one answer, but gabapentin can be used to treat neuropathic pain that just goes right to the nerve. Benzodiazepines, they make you less sensitive to stimulation and can be effective. Tricyclic antidepressants, TCAs, increase norepinephrine and serotonin is the feel-good neuroreceptor. So more serotonin, you'll feel better, and SSRIs will make you feel better, also work to elevate that level. All of these drugs have side effects, so nothing is perfect. So they're definitely worth using, especially in the SSRIs are very effective for the persistent genital arousal syndrome, but with the guidance of a physician who is comfortable prescribing these and knows how to adjust them, because they need to be at the right levels. Pelvic organ prolapse, again, you're going to get a much more detailed lecture, but any organ can be involved. It can occur at any age, pre-pubertal. You don't have to have children. With the abnormal connective tissue of hypermobility and EDS, this is just something that there's a greater risk for happening. It doesn't particularly, many studies have been on childbirth. It hasn't really been seen to be particularly exacerbated, although it can be with childbirth. And the one little caveat was you sort of don't think about it, oh, I've never had a child, or gee, my 11-year-old is complaining of this pain, that's down, that seems to be in the vaginal area. Keep in mind, it can happen to anyone. So to keep it in thought, if there is something like what's this mess that I feel down there? And again, it could be the bladder coming down, it could be the uterus, it could be the rectum, or any combination of all of those. All right, and we're not done yet. Women have to go through so much, right? So endometriosis has always had a sort of rumor, oh, that's associated higher rate with EDS. I don't think so. The more recent studies show it's just the same as the general population, but anywhere between 6 and 23% is what we find in the literature. Uterine myomas are actually quite common. So to me, this rate is lower than the general population, but anyway, they certainly don't seem to be occurring at an increased risk. And infertility, again, I've got a bunch of studies that say, no, really, there's no difference. Fertility is perfectly normal. And then you'll have a couple of studies that say maybe it's as high as almost 50%. Again, this could be a little bit of bias in those higher numbers. There's no real mechanism for infertility, so I'm more inclined to think it's not particularly higher, but certainly if you have, if you're a woman, you can have certain infertility for whatever reasons. 10% of people are at increased risk of infertility in general in the general population. So just address it as you would address any woman with infertility, or any couple with infertility. All right, and now we got to the good part, menopause, when all of those hormones go away again. So they will improve once you go through menopause and those hormones diminish, about 22% of women in the one, there isn't that much data out there, but in one study, 22% said, yeah, I went through menopause and my EDS symptoms, they just got better. And some individuals did use hormones for, as a matter of fact, 42% used hormones to transition through menopause. And 15% of those women said, oh, I feel like my symptoms improved. Well, that's kind of the same number as people who didn't take treatment. So I don't know that hormonal therapy, I don't think it caused any problems, but it wasn't really helpful for EDS when compared to the people who didn't take the medicine. All right, so that is the end of my talk. I'm looking forward to doing the live question and answer session with you. And then I actually took this photograph this morning. I was looking forward to being in Phoenix and seeing there's a wonderful botanical garden. Might be a little hard to, or hot to go around in the summer, but here's my cactus that I've got ready to have the one flower that I get out of all my cacti. But anyway, next year I look forward to seeing many of you in person in Arizona. And thank you for your attention.